I don't know where you are, but it's certainly lovely and sunny here. And thank you so much for taking time out of your very busy afternoons to come and come to this webinar. So my name is Susan Oza. I'm the founder CEO of One2One Mentoring Network and also a consultant pediatrician at the Eastern North Hertfordshire NHS Trust. So what we have today is a very, very informative webinar. So most of the times we've done in the past panels where we had invited people to talk about different topics, but this particular webinar is different. It is a webinar. I have in store for you all an expert panel of very, very informative professionals who are going to be talking about the COVID-19 vaccines. I know there's a lot out there about the COVID-19. Should we take the vaccines? Should we not take the vaccines? So what we've done this time is to let all the presenters present the facts. I just want to say that this is not a webinar to convince people to take the vaccine. All what we are trying to do is to present the facts, to present the evidence. And then when you get the evidence, you make an informed choice about whether you feel you want to take the vaccine or not. So I hope you find it very useful. A little bit of a housekeeping. As you know, this is very virtual, and as usual with anything that we do virtual, things can go wrong. Some of our presenters might be presenting and the internet might go very funny. Welcome to the virtual world. We now are all very used to using the Zoom platforms and all the other platforms. If you're not using your video or you're not talking, I would really encourage you to mute yourselves and then put your video off. Okay, so that is me done. I'm going to hand over to our beautiful and amazing Mrs. Samantha Prosser. Over to you, Sam.
Thank you very much, Susan. I appreciate it when I get these amazing accolades, you know. So hello everybody, and welcome again. It's always nice when we have these sessions, and I think suffice to say that this is something that's very important that we need to have the conversation about. So without further ado, I'm going to try and start off by introducing my first speaker. Now, this first speaker is Dr. Michael Ogundele. And Dr. Michael, the question I will be asking him, the way the format is going to be today actually is that, okay, so I'll pretty much tell you how this is going to be. We have 5 different speakers. And the way the format is that we each person will be asked us a question. They will then give us whatever what their answer is around it, and each will move from sort of one speaker to the other. So at this point, we keep the audience questions down. But then we would suggest, please, that you pop any questions into the Zoom chat because that's being monitored by Marvin. Marvin is doing this very ably and capably for us. So the information will all be pulled together, and then what we'll do is then we will be sending this. We will then have this. We'll be asking the various speakers about these questions. All right, so that's really the format, very different from our usual where we have panel talks and we chat and then essentially people ask questions later. So that's how we're going to do it. So I'm going to introduce Dr. Michael, and once I've done that, I will then tell you what question I'm going to ask him, and then he will do his job. So Dr. Michael, Ogundele received his medical training at University of Ibadan College of Medicine in Nigeria, completed with distinctions and receipt of several distinguished awards. He completed a research fellowship in immunology and a postgraduate training in medical informatics in Germany. Dr. Ogundele has also completed postgrad training in tropical child health, pediatric neurodisability, and software technology. He has completed a formal training in mentoring and coaching. He has worked as a consultant neurodevelopmental pediatrician in various NHS trusts in England and Scotland, and has published numerous scientific articles and book chapters on immunology. Dr. Michael, welcome.
Thank you very much, Samantha, for the very nice introduction.
That's good. So then the question that I have for you is, what is COVID-19 and why has it been shown to disproportionately affect the Black and Asian minority ethnic community?
Thank you very much, Samantha. Good afternoon, everyone. I'm just going to share my screen for you while I go through my presentation. So, can you all see my screen?
Yes, we can.
Okay. So, thanks very much for having me here today. So, I'm just going to start by asking the first question, trying to answer the first question. What is a virus? A virus is a very tiny particle consisting of an outer lipid or protein envelope with either DNA or RNA in the center, which instructs the reproduction of the virus. The virus by itself cannot survive for more than a few hours outside of the body. It requires a living body, a living cell to be able to reproduce itself. You can see the picture there of an envelope with the genetic material in between. COVID-19 actually means coronavirus infectious disease, which was discovered in 2019. The virus is a new type of virus which belongs to the category of severe acute respiratory syndrome coronavirus type 2, because type 1 was discovered in 2003, and the name corona comes from the spike proteins on the surface, and that's where we get the name coronavirus from. Coronavirus has caused a worldwide pandemic. So this is just a little bit of statistics in the last 1 or 2 days. Almost 120 million confirmed cases of coronavirus corona cases have been confirmed all over the world, and we are getting almost 500,000 cases every day. And we have recorded 2.6 million deaths, and that is all over the world. The US, unfortunately, has seen the highest death rates worldwide, followed by India, 11 million, Brazil, 11 million. Those are confirmed cases, and followed by UK, just more than 4 million confirmed cases for the past 1 year. As you can see, coronavirus or COVID-19 is not a peculiar disease of Bain, so that some people might say, okay, maybe it was particularly designed to cut down the population of Africa. That is far from the truth. The entire Africa has confirmed cases of just about 4 million, compared to 38 million in Europe, 52 million in America. So COVID-19 is not a disease that is disproportionately affecting Bain people in their natural community. And we know that vaccination is a worldwide response. The vaccine was not designed for any particular ethnicity. In fact, the widest use of vaccine has been in Israel, followed by United Arab Emirates, And of course, UK is just staying behind, and we have vaccinated just over 35% of our adult population. It is a known fact, without any controversy, that the ethnic minorities in Europe, in the developed countries, have borne the brunt of this disease. We are at higher risk of contracting and dying from the disease compared to the rest of the European population. Even for example, in the Chicago, with a population of Black minority of 32%, 72% of those who died in the first few months were Black people. And also in the UK, the first 35% of the first set of people who got the virus were Black and ethnic minorities, compared to just 14% of the normal population. And the question somebody might ask is, why BAME? Why us? Why are we suffering much more than other people? Of course, that answer to that question is complex and it's not straightforward. But it could be any of these things that we have seen here on this picture. Either not having access to testing or reluctance to have a test, living in high density areas, exposure to pollution, and so on and so forth. I've just tried to highlight a few points of things that are confirmed and other things that are probable. But these things are difficult to research, and that's why nobody has been able to come out with any clear-cut explanations why ethnic minorities are at increased risk for this virus. Number one is income inequality. We know that the ethnic minorities earn less on average than the white majority population, and that in itself, poverty in itself, leads to a lot of other comorbid, a lot of secondary consequences like diseases, food security, health outcomes, and so on and so forth. The next thing is educational inequality. We know that education translates to additional chances in life, increased employment prospects, increased income. So there's a wide discrepancy between the educational level and the educational access of ethnic minorities. We also have the possibility of harmful environmental factors. Poor people are more likely to live in crowded houses where it is impossible to do any social distancing, and they might live closer to industrial areas, either because of employment opportunities, and which are the areas where you have increased areas of pollution and predisposition to lung diseases. And people have noted, rightly so, that people who are exposed to chronic stress, similar to what you get on a daily basis, exposed to institutional, interpersonal racism every day, they lead to production of stress hormones which suppress natural immunity. And the next is occupational hazards. Ethnic minorities are more likely to be key workers, taxi drivers, retail workers who are exposed to a wide range of random people on a daily basis, and their chances of contracting the virus is increased, especially people who are living in London, in and around London. There could be problems of access to medical care, even though NHS is free at point of care. Unfortunately, many of the ethnic minorities are less likely to make use of the free NHS services, with more, maybe better faith in alternative complementary medicine, or just not wanting to go to this hospital for one reason or the other. There could be cultural and language barriers. People who are not speaking English as their first language may not trust anything that they hear from the social media or from the official social platforms. And people who don't understand English will find it difficult to understand what's going on in the community. There are definite biological disparities. Dark skinned people are more likely to be vitamin D deficient, and we need yearly supplements to boost our immunity. And also, of course, there are also other biological explanations as well. Research has shown that the immune response between the European ancestry, is actually different from African ancestry. And that may make us either immune or more susceptible to certain types of infections. It may just happen that our immune response to COVID-19, to coronavirus, is a little bit giving us a disadvantage. So as a result of all these things that we have talked about, so I just want to leave you with some learning points. What are some of the things we can learn from our increased vulnerability? So it's important for us to listen to what is going on, try to find out what's going on around us, and just to be conversant with information that the government and the authorities want to pass across. Because if you don't know what's going on, we may be at a disadvantage of knowing what to do. I've just noted that we are at increased rate of having vitamin D deficiency. And it is recommended that everybody, every dark skinned person should have vitamin D supplement every year, at least in winter and autumn. It's important for us to take sensible precautions, including social distancing, face mask wearing, and even taking the vaccine as well. These are all things to protect ourselves and to reduce our vulnerability to this virus. And please, I want to beg us, let us make use of the NHS. It is free and it is already paid for from our taxes. So there's no need to shy away from using NHS for whatever reason. And of course, we should take care of ourselves. Let's do our annual checks, especially if you are more than 50 years old. And we should also aspire to higher things, keep aspiring to higher levels in our employment ladder, because that will also protect us in one way or the other. The sky is the limit. Whatever the mind can conceive, it can be achieved by a man or woman. And we should surround ourselves with mentors and people who will challenge our status quo and help us to move forward. Find helpful, meaningful ways to relax and overcome the daily stress that we're exposed to, not indulging in alcohol or smoking. Walking and exercise is a good way of distressing every day. And of course, don't forget your spiritual well-being. Maintain your social contacts through phone calls and religious groups. And this may sound a little bit controversial, but if you can, move out of London. There are lots of other nice places to work and live. And it's time for us to try and eliminate this racial discrepancy, not just in the infection, but also in vaccine uptake, which is something we need to protect ourselves. Thank you very much for listening. I will be happy to take some questions after.
Thank you, Dr. Mike. Do you know what? I felt as if I was kind of like sitting in like my, going to a GP surgery and being told, afterwards that, the NHS is free, you've already paid for it. So don't forget that. Look after your health. And on top of that, move out of London if you can. There are nicer places to be. But thank you very much. I think the serious message there, though, is good, because you've explained to us about, COVID and how it all comes about. And I think crucially, when people see, look at the numbers, it is incredible that the numbers in Africa are actually so much lower, and we're so thankful for that as well. But we keep praying that we actually come to the point where we actually don't have to have these things anymore, these discussions anymore. So I'm going to hand back to Dr. Susan. Thank you very much, Dr. Mike. And I'll hand back to Dr. Susan so that she can do the next person, please. Thank you. Susan, you're on mute.
Oh, the rookie mistake. Thank you so much. I can't remember making that mistake, but thank you. But yes, thank you, Dr. Mike, for that very informative talk that you just did. So I have the pleasure. Yes. Now the reason why I'm smiling is that this is one colleague that I have a lot of respect for. Very generous colleague, Dr. Lynn Ventilation. We are both colleagues at the Leicester Hospital, and which is the Eastern North Hertfordshire NHS Trust. I have known Lynn for quite a number of years. She is a consultant pediatrician, with special interest in pediatric allergy and runs general and pediatric clinics at the hospital. She completed her pediatric training at the London School of Pediatrics and trained at King's College and St. Thomas Evelina Children's Hospital. Dr. Vaccination is the clinical lead for pediatric allergy service and infection prevention and control for the Children's Division since 2017. She has led and she actively, strongly led our Children's Division during the COVID-19 response and did a fantastic job. So it is my absolute pleasure to invite you. And your question, Dr. Vaccination, is what are the reasons behind the public health messages? For example, social distancing, wearing masks and washing hands to prevent COVID-19. And I know that you are very passionate about infection control. Over to you. Thank you so much.
Great. Thank you so very much, Susan. First of all, for inviting me and to be amongst a privileged speaker panel today, and also to share my experience as lead for infection control at the Lister. As you know, Susan, we have been the first division to actually ask for approval for the wearing of masks for all the medical staff in order to prevent the transmission of coronavirus. So I'm just waiting for my slides, and I really would like to share the importance of this public health measure, because hands, face, and space do not necessarily mean just protection from the virus, but it has far-reaching implications, not just on our societal level. And this is the government poster that you've probably seen all across during all the government updates and various meetings as well. Next slide, please. So I would like to really focus on why it's very important to pay attention to public health measures. Public health is defined as the art and science of preventing diseases, prolonging life, and promoting health through organized efforts of society. And this was from WHO in 1988. But we're talking about a global pandemic, wherein we're not just committed to promoting health and life in our own societies, but we're transcending beyond societies and impacting on global health. Next slide, please. So what are the reasons behind the public health messages? We may have heard this over and over again, and every one of us has access to the internet, and all of the searches would show lots of systematic reviews, lots of journal articles, opinions about this, but it all boils down to very simple, very effective measures: the washing and disinfection of hands, wearing face protection or face coverings, and also keeping safe social distancing of 2 meters. And I will tell you why later on in my next slide. And the answer really lies on the very simple nature of transmission of coronavirus. So coronavirus, as what Dr. Mike Okindele has highly highlighted earlier, it is a respiratory virus causing respiratory symptoms. And that transmission is mainly via droplets or particles of liquid, which when it comes into contact with our eyes, nose, and mouth, this could be an entry point to entering the body and infecting the host. When the droplets fall on contaminated surface, for example, door handles, tables, and various external surfaces, and we touch these surfaces and eventually come into contact with our eyes, nose, and mouth when we touch our face, this could lead to transmission and infection of the virus subsequently. This is a very good illustration. This is on the BMJ, and it tells you about the route of transmission of coronavirus. As we can see, infected individuals can transmit infected droplets into the air, and these can then be passed on via direct contact by shaking of hands, kissing, hugging, or also by close contact of these droplets into the entry points of the nose, mouth, and eyes. And I've already mentioned about how droplet infection or droplets can lead to infection when we touch surfaces that are contaminated by them. Next slide, please. So how do the public health measures prevent transmission? I've already alluded to this, but in my next slide, we know that, sorry, if you can go to my next slide, please. We know that if we maintain safe social distancing, at least 1.5 meters and beyond, we can prevent the droplet from coming into contact directly with our eyes, nose, and mouth. And we prevent the transmission also by wearing a face mask or face covering. And I think WHO recommends an N95, but also any facial covering, which is evidence-based. We know that this transmission is not possible or is significantly reduced. So this is published on the SAGE, the government advisory group, by Liu et al. In 2017. And this just highlights the mechanism of exposure from coronavirus. If you can see the graph, letter A, it shows the distance from the infection source. From 1.5 meters and beyond, there's a significant reduction of the risk of infection. And on graphs B and C, we note that once again, from 1.5 meters, there's a significant reduction for high large droplet exposure and high airborne exposure to coronavirus and airborne viruses for that matter. Next slide, please. Contact with contaminated surfaces will not lead to infection if we effectively wash our hands and do this age-old infective prevention and control measure. We know that this has prevented infections in various parts of the world, and not just with coronavirus or other respiratory viruses, but all infections, including those that have infected those children and adults who have been infected with tropical diseases in various countries, not just in Asia, but the rest of the world. And why do we have to do these measures at all times? Why can we not let our guard down? It is because individuals can transmit the virus even when they're asymptomatic. There are individuals who develop symptoms 2 to 3 days or up to 5 days before the onset of their symptoms. And therefore, during this time, they could be very infective. When we let our guard down, we know that we can affect society because the transmission of the virus does not affect just our communities, but has far-reaching effects. Next slide, please. The impact of coronavirus, the impact of coronavirus pandemic in the world has far-reaching effects, not just for our health, but also for our economy. Next slide, please. The global morbidity and mortality has been published weekly by the Johns Hopkins Center for Systems Science and Engineering Statistics. And we know that over 118 million have been affected so far, and nearly 3 million have died all over the world. Next slide, please. I am not an economist, but we can see from this graph from the IMF, published in February 2021, that there is a contraction and a negative growth on economy, which has been more felt this great lockdown in 2020 compared to the global financial crisis in 2009. I come from the Philippines and from Southeast Asia, and although I do not understand very clearly, being not an economist, about GDP, this graph and this figure shows to me the effects of it on poverty. And we can see the yellow bar graph there of South Asia, for example, wherein there are hundreds and millions of people who have been pushed down beyond the poverty line. And the red reflects people in Africa. And most certainly, this is not just isolated in these areas and regions of the world, but also other parts of Europe, Central Asia, and North Africa. Next slide, please. I would just like to take your attention to the latter part of this statement. As a consequence, COVID-19 could push as many as 34 million people into extreme poverty in Africa, erasing at least 5 years of progress in fighting poverty. This is basically going back to square one, We're not talking about the health implications, we're talking about poverty and the implications of that for the rest of the world. Next slide, please. This does not only mean contraction in the economic growth of various countries across the world, but also the aid commitments by country in various income groups. If you can see here from 2018 to 2020, this very small 2 to 7% all across the high income, low income, and medium income countries, their aid commitments have significantly shrunk because of the pandemic. Next slide, please. So I would like to highlight once again this very simple public health guidance and public health measure of safe social distancing, hand hygiene, and maintaining a face covering when in close contact with people around us. Next slide, please. Because these simple public health measures have a big impact. They may be simple, they're evidence-based, and all of these have been tried and tested measures across all across the world, globally, for various pandemics, not just this one. Next slide, please. So I would like to thank you for listening. I did not put in so much information because all the public health guidance is accessible on the Lancet, on the BMJ, and WHO guidance, and also the government websites. But I would like to highlight, more importantly, that we are all interconnected. And the simple public health measure is not just for you and me, protection for us, but it's also an impact that we can all make towards the health of the world, not just global health and physical and medical health, but also mental health and economic well-being of the rest of the world. So with that, I would like to thank you all for your attention.
Thank you so much, Dr. Ventilacion. Very clear, strongly presented, a sober reminder of the impact of the virus on the economy. Very simple, 3 simple messages: maintain social distance, wear face masks, and wash your hands. Pure and simple hygiene. Excellent. Very, very, presented very clearly, succinctly, articulately, and very strongly as well. Thank you so much.
Thank you so much.
With this, you're very welcome. Thank you. So with this, I'm handing over to Mrs. Samantha Prosser. Thank you. Thank you.
All right. Thank you very much. And thank you, Dr. Lynn, as well. We appreciate everything. So the next speaker is Mrs. Sedina Agama. And Sedina has been a good friend of mine for years and years. So I do know her very well. And I happen to live also quite close to her. And before I even sort of tell you about her, this is a woman who has kind of like her sole mission has been to get the message out there. She has been out there vaccinating herself at some mosques, at the temple, at in churches, and setting up clinics over in her borough of Merton. So I'll tell you a bit about Sedina. So Sedina is the chief pharmacist, Merton Borough, Southwest London Clinical Commissioning Group. And Sedina is a highly experienced pharmacist who has worked in primary care, supporting GPs, nurses, and other healthcare staff since 2000. Prior to this, she worked as a specialist clinical pharmacist in cardiothoracic medicine and surgery, as well as ITU pharmacist, medicines information pharmacist, and clinical trials pharmacist in a number of London teaching hospitals. Sedina is currently working in a COVID vaccination clinic and has a keen interest in ensuring people have the right information to make their own individualized, informed decisions. She currently works with other clinicians on regular COVID vaccine webinars in her borough and CCG. So welcome,
Thank you, Samantha. So nice to be formally introduced, because normally you and I are having a right old giggle and nothing as formal as that. So I'll try and be on my best behavior. Hello, well, thank you for having me, and I'm honored to be able to talk to you this afternoon about the vaccine.
Yeah.
As Sam says, so since I would say the beginning of December, I think my whole life has just been about the vaccine and everything that goes with it. So hopefully, by the end of my talk today, I'm able to impart some of the knowledge and bust some of the myths that there are around the vaccine. Okay, so this picture was from yesterday. So yesterday, our roving clinic was at the Temple. And the whole idea of the roving clinics as part of the COVID vaccination program is to take the vaccine out into the community, into areas where people feel more comfortable, and also where their leaders have spoken to them about the vaccine and then encouraged them to have it. So it's all about giving the vaccine in an area that people feel comfortable with. But the question really is, why vaccinate? And I think our first two speakers have very eloquently explained to us about the infection, explained to us the impact that it's having. To be fair, we all know how tough it's been. I can't believe it's been a year since we've been under lockdown. We haven't seen our loved ones in a year and more. It's been incredibly difficult. People have lost their jobs, people have lost family members, depression, anxiety is at an all-time high. Children have lost out on their education. So we're all desperate to get out of this situation. And now we have a vaccine. It's quite exciting. I remember just feeling totally emotional the first day that the vaccine was authorized in the UK, because finally we could try and do something about this awful situation we find ourselves in. There are lots of vaccines in use. There are about 14 vaccines out there that are commonly used across the world, and they are designed to prevent people from getting serious infections, reduce hospitalization, and in turn prevent death. Now, as an NHS a member of staff, I have seen how hard it was for our hospital colleagues at a point when there was no vaccine and all they were doing was trying the ultimate best, trying all the different treatments, trying to figure out how to deal with this situation. So actually having a vaccine for me is quite exciting, because finally we can prevent that situation and our NHS can go back to the business as usual. Because guess what? While we're trying to fight this horrible disease, everything else is on hold. So people are not getting their blood tests in the timely manner. People are not seeing their consultants and their specialists for diagnosis or follow-ups or treatments in the same way that we could before. So it's quite important that this vaccine is implemented to really save our health system, but also to bring our lives back to normal and also to our economy. It's much safer for your immune system to learn to fight this illness through vaccination than by catching it and then being treated for it. A lot of people say to me, well, but I've had COVID, why do I need the vaccine? We know that those antibodies, they wane, okay? So the vaccine is about boosting our immunity and having some antibodies that will last longer than the ones that we'll get when we have the disease. And at the moment, it's the best protection against the coronavirus infection. So really important. Next slide, please. So the vaccine itself is safe and effective. Every single day, there is new information that comes out against the vaccine. So the picture you can see there is a picture of me holding the vaccine. That's the Pfizer-BioNTech vaccine. We're using the Pfizer-BioNTech vaccine. We're also using the AstraZeneca vaccine here in the UK, and we will start to use the Moderna vaccine soon in the UK. In other countries, there are different vaccines being used. The key thing is that they are all safe and they are all effective. Now, I've been a pharmacist for almost 30 years. And as you heard from my bio, I've worked in various specialties, and we've had lots of novel treatments come out and drugs that we've been excited about and etc. But I can tell you this COVID vaccine is probably the most monitored medical intervention in recent times. We're all at home in our armchairs. We've all become vaccine experts. We're also interested in everything going on. And it is being monitored both by us, the public, but also by the specialists, the scientists, the companies, the regulatory bodies, etc. It's been given to millions across the world, and here in the UK, over 23 million people. As I'm speaking to you now, the two clinics that I work in, they're open to 8 o'clock. So more and more people are getting immunized every day. But the key thing, as we just heard from Lynn, is we still need to observe the COVID safety protocols, hand, face, space. We still need to do that for now. But there will come a time when we won't have to do that. But the more people that get vaccinated, the sooner that can happen. And remember that when you're vaccinated, it's not just about protecting you. It's about protecting your family, your friends, your community, your country, the world at large. Next slide. So the vaccine itself, as I said, there's several vaccines and they're more emerging all the time. I get asked a lot, but how come the vaccine was developed so quickly, et cetera, et cetera? You know, it can't be safe, it can't be right. Well, this is one product that has been developed with a huge amount of collaboration worldwide. It's had huge amount of financial backing by governments. It's had robust, extensive testing for safety and quality, and nothing has been compromised. So none of the regulatory bodies would have compromised their testing. They would have done exactly the same testing. The key thing is that the way in which the trials were conducted overlapped with each other. But also, I think we mustn't forget that a lot of the knowledge around treating these infections, developing these vaccines, has been developed over the years. And when we were faced with this situation, we didn't start with a blank piece of paper. There was a lot of expertise out there. And what we were trying to do was learn about this vaccine, learn about the virus and use its characteristics to develop a vaccine that works and is safe. And every single country that uses the vaccine will review the trial information, and before they give it what we call the emergency authorization. So they will be satisfied that it's safe and it works before they agree for it to be used in their country. Next slide, please. Most of the vaccines require 2 doses to confer full immunity. So you need to have your first one. And after you've had your first one, it takes about 2 to 3 weeks before you have any immunity developing. And then you need to have the second dose. There is one vaccine at the moment, which is the Johnson & Johnson vaccine. That is just a single dose vaccine. We're not using that one in the UK, but it is being used in the United States. The key thing is that different countries have different dose intervals for different reasons. So it ranges anything between 3 to 12 weeks. Next slide, please. So that's a picture of me having my vaccine. I had my vaccine on the first day within my clinic. And as I said, you know, the protection doesn't start straight away. Obviously, working in the clinic, it was quite important that the staff that were going to be immunizing had a level of protection with time, because obviously we were coming into contact with different people every day. The very exciting thing, as we can see for those of us in the UK, is we can see that the cases are substantially reduced. I was on a webinar yesterday with an intensive care consultant, and he was telling us how on Christmas Day in his hospital, they had 150 critically ill patients. And yet, as of yesterday, they had 5 people critically ill. Isn't that amazing? And for me and my colleagues who have been working tirelessly to get everybody immunized, it's exciting to see that it actually works, and serious illness and hospitalization as well as death is reduced by almost 50% across the board, particularly in the patients that had their doses first. Now remember, we immunize in an order of risk of infection from what we could see. And the data that we see now is from those that were immunized first, and they've only had their first dose. So we can imagine what's going to happen when they have their second dose. So that's really exciting news. Next slide, please. So busting the myths. Now, the picture that you see here, by the way, I take all these pictures. I'm one of those people who's always got a camera, constantly taking pictures. My team are laughing all the time. But on this day in the clinic, it'd been a week where there was a lot of information about, you know, people in the BAME community are not taking the vaccine, and it was getting very frustrating for all of us. And as I walked around the clinic, I saw this picture. So you've got one of our nurses, Sylvia, who is immunizing the lady. Now, I tend to talk to the patients in the clinic and try to understand how they're feeling about it, if they've got any questions they want to ask me, or sometimes I ask them, you know, what made you come to the clinic? So this lady that's been immunized, she's a counselor in one of our deprived communities. And she was saying to me, well, she deliberated for ages. She'd spoken to one of my colleagues who'd been encouraging her to come. And then she suddenly decided in the week where there was a lot of talk about BAME not stepping forward to have the vaccine, that she would set the example for her community. So, and then after I took the photo, she said to me, you know what, I want that photo going everywhere, even if you have to put it on billboards, on magazine covers or wherever. The interesting thing is the picture that you see in the background, also has her on it. And it was quite purely coincidental. So she's somebody who really wants to get the message out there. And I thought it is a useful picture to share that our people are stepping forward, our leaders are stepping forward, and we are part of the teams that are doing the immunization. And so when it comes to busting the myths, we're in there. Now, my responsibility for the vaccine, I share with the clinical leads for the clinics that I work with. So together, we need to make sure the vaccine gets used, that it's stored properly, that it's used properly. And so for us, these myths are things that we really are keen to bust. So the vaccine does not contain any animal material. It absolutely does not contain any tracking devices, okay? To be honest, the phones that we carry around with us are more of a tracking device than the vaccine. The material will not alter your DNA, or it's not designed to wipe out the Black population. Dr. Mike explained in the beginning, we're all using the same vaccines. And quite often when I meet hesitant patients and they're worried about this, I say, well, look around the clinic. There's not just Black people in here, there's all manner of people. I am responsible for the vaccine, but for it being diluted and drawn out. And I can assure you, none of the syringes are labeled for Black people. You're randomly going to get one of these syringes. It doesn't leave you with a 666 mark on it. You know, it's not anything evil. It's not to do with the Antichrist. It is there to protect you. The other thing people ask me a lot about is it suitable for me? I'm a Muslim, I'm Jew, I'm Sikh, I'm Christian, etc. All of our faith leaders have declared it safe, and you would have seen various people, various religious leaders taking their vaccine for us all to see. Next slide, please. I get asked about infertility and pregnancy a lot, particularly by the younger women. There is no evidence that the vaccine causes infertility, and to be honest, there's no medical reason to believe it would due to the way that it works. Now, at the moment, it's not routinely offered to pregnant women. However, many pregnant women have been offered it and they've had it, particularly if they're a high-risk person. So if you've got underlying conditions as it is, if you're working in a high-risk area, which a lot of healthcare staff are. So amongst my colleagues, there are many young women who have had the vaccine. There are many pregnant women who have had the vaccine. And the evidence of the use of the vaccine in pregnancy is developing all the time. And for the men listening, or even for the women, there is no evidence that it causes erectile dysfunction. I had a very interesting conversation with two young Black men who came into the clinic, I think it was on Wednesday, and they came in with their partners, and the partners were taking photos saying I was talking to them, and they said, you know what, we're taking this picture because we want to show the brothers out there that, you know what, it does nothing. And actually, it's going to be our partners who are going to say that it doesn't cause erectile dysfunction. It's not even going to be us. And we had a good laugh about it. But it is important that people see and hear this. Yesterday on a webinar that I did, there was a lady who came on the chat and said she knows for a fact it doesn't cause infertility because she had a friend who had been trying for a baby for 6 years. And she had her vaccine in January and she's now pregnant. Isn't that great? So we know it does not cause infertility, so nothing to worry about. I think that's my last slide. Is that right, Marvin?
Yes, you're right. That's your last slide.
Thank you very much for listening. I hope that I've busted the myths. I've answered your questions. And if I haven't, please pop them in the chat and we'll answer them all at the end. Thank you for having me. Thank you for listening.
Oh, thank you so much, Sedina. That was really good. It was such riveting. You know, I was listening, you know, like I've listened to absolutely everybody anyway. But I think what's incredible is, you know, you've talked about the real need for us to get vaccinated, and the why vaccinate is the key thing. And you tackle the issue that people worry about, the fast production of the vaccine. That's just been fantastic. And to see this very distinct drop in critically ill patients, you know, serious illnesses and hospitalizations, all reduction, which we can say has a direct correlation between getting vaccinated, you know, and not. So I think, and infertility, I've got to get my teeth in, and pregnancy, which is something that worries a lot of, I've spoken to various people, particularly young people who've been very concerned. And I think it's wonderful to hear that, because I think the last time we had a webinar, someone was saying, do we know anyone who's actually been pregnant since? And we said, oh, this hadn't been going on long enough. So I think this is fantastic to hear. So thank you very much again. And we really appreciate everything that you've done for us. I'm going to hand back to Dr. Susan.
Thank you. Thank you very much, Samantha. Thank you. Okay, so we're going to go to the next speaker, and it's my pleasure again to invite Dr. Dorcas Owusu-Yanima to present. Now, Dr. Dorcas is not just a colleague, but we go a long way. She's actually a friend and a sister. She is a GP partner in a multicultural and ethnically diverse area. She is a GP trainer involved in training junior doctors and GP trainees attached to the practice. She believes that as health professionals, we have a responsibility to educate our community in order that people can make an informed decision regarding the COVID-19 vaccine. So she is very passionate, as you can see, and I know that she is really doing a lot of work, being invited to various places to talk about the COVID-19 vaccines. So Dr. Dorcas, your question is, what are the adverse effects of the vaccines, and how do we know that the vaccines are safe? Thank you.
Good afternoon, everybody, and thank you for your introduction, Susan. Right, so as part of my introduction, what I'd like to say is that like any drug or medication, which has some side effects that are listed, the vaccine also has side effects that are listed. However, these side effects are generally quite mild or moderate, and they tend to be short-lived as well. Please could I have the next slide? So on my first slide, you can see what are considered to be very common side effects. And the very common side effects are those that affect over 1 in 10 people. So you can see that most people who are having the vaccination will have maybe 1 or 2, or maybe even more of these side effects. Having said that, I have had colleagues have the vaccine who have said, well, I didn't feel anything. All I knew was that I had a vaccination, but absolutely nothing. So when you look at these side effects, they are typical of a vaccination. For instance, if you got the flu vaccination, you might have some tenderness or soreness at your arm or at the site of injection. Some people feel a bit non-specifically unwell, or feel a bit feverish with chills or muscle aches, etc. But it's important to stress, as I said before, that these effects tend to last maybe maximum 3 days. And what we do advise people is that if your symptoms do go maybe up to 7 days or beyond, then you probably need to contact a health professional. I had a lady earlier this week asking whether an effect of a rash and diarrhea that she had after her vaccination 4 weeks ago was an effect of the vaccine. Now that was a bit difficult to prove. She thought that it might be an allergic reaction, but typically allergic reactions don't tend to last that long. So sometimes there are some effects that we are not sure are actually a cause of the vaccination, or whether they happen to have happened at the same time, whether it's coincidental. All right, so let's move to the next slide, which tells us about common side effects, which is basically up to 1 in 10. So as you can see, there again, having diarrhea or flu-like symptoms are some of the symptoms that people can commonly have. They are not serious. And if there is discomfort that is significant, one can take paracetamol that will help settle it down. Okay, could we go to the next slide, please? These are uncommon. These are probably up to 1 in 100. I haven't yet come across somebody feeling dizzy, but I've definitely come across someone who has had a reduced appetite with the vaccine. I haven't seen anybody with abdominal pain, but I have met someone who has had some lymph nodes in the armpits and has asked me whether it was associated with the vaccine. And I did say that there is record that some people do get enlarged lymph nodes, but these tend to disappear and they don't cause any significant issues to the recipients of the vaccine. Okay, so these are the uncommon ones. I just want to talk about one or two side effects that have been recorded, which are thought to be rare, and one that is thought to be very rare. So please, can you move on to the next slide? So particularly with the Pfizer vaccine, we are aware that there have been a few recorded cases of a very severe allergic reaction, what we call anaphylaxis, which requires hospital intervention with, giving adrenaline, steroid injections, and which can lead to actually needing some help with your breathing, because anaphylaxis can cause swelling to the throat, difficulty breathing, swelling to the lips, as well as a rash. Now, events associated with inflammation of the nervous system have been documented. There have been records, which are, I would say, very rare. So a side effect that is thought to be rare, as in the anaphylaxis, would be in the region of, say, 50 people in 100,000. But as I said, there were just a few documented, particularly for the Pfizer vaccine. And because of that, if somebody has a history of very severe allergic reactions or anaphylaxis, they tend to be offered the AstraZeneca vaccine at the moment in the UK, rather than the Pfizer vaccine. Also, if somebody has one of the vaccines and they have a significant reaction, then it will be recommended that they have the other vaccine or another vaccine. So, for instance, this lady I was talking about who said to me that she had had diarrhea for 4 weeks, which we are investigating anyway, because we don't know whether this is associated or not. We had a discussion around what she could have the next time, perhaps have the alternate vaccine. She had had the AstraZeneca vaccine. So we said perhaps next time she could have the Pfizer vaccine, or if the Moderna vaccine is available, she can have that. Now, coming to these events associated with inflammation of the nervous system, we are talking about maybe pins and needles, numbness, loss of sensation. Those are some of the effects that have been documented. However, there isn't clarity as to whether this is a causal effect of the vaccine or whether it is just a coincidence. Some of you may have heard in the news in the last week that out of 5 million vaccines that have been rolled out in Europe, there have been 30 documented cases of blood clots. The BMJ from the 11th of March has stated that the incidence of these blood clots has not been found to be any more than you normally have in the general population. So whilst this is being investigated, the European Medicines Agency has said that the vaccine rollout should not be halted. It should carry on whilst the investigations are going on, because at the moment, there is no causal relationship that is established. And also, clots in the general population is something that can happen anyway. And as I said, this is not any more than has been found in relation to the vaccine. The COVID infection itself is associated with blood clots, which have been known to cause, significant illness in people and sometimes death. So we are going to watch this space. The other thing is that because this is an evolving situation, side effects are still being monitored. So if someone should have an effect after having a vaccine that is not already documented, then you are encouraged to report that to a regulatory body in the United Kingdom, which is the MHRA. So there's this yellow card system that allows people to report any side effects. And as you can see, there is an app store that enables you to have access to reporting quite easily. And by doing this, it makes it possible for more information to be gathered as the situation evolves. As my friend and my colleague Sedina said earlier on, the vaccine has not been associated with either issues with pregnancy or fertility at the moment. Anyway, there is no concern regarding that. And also, the way that vaccines behave, there hasn't been found to be any plausible reason in terms of how a vaccine works that would cause fertility issues or even the blood clots that I said about. No vaccines have been found to have a relation with blood clots. Now, this question about how we know the vaccines are safe, I think has been quite well elaborated by Sedina as well. But it's just for us to remember that before the vaccines were approved to be used, they had very, very rigorous checks, very rigorous monitoring. And just as any drug has to be rigorously tested before it's released into the general public or to the general public, that's the same thing that has happened with these vaccines. And some of you may recall that Sedina said that actually, these vaccines have had a lot more monitoring and attention than other medications that have been released into the general public. So for instance, some drugs have had just phase 1 trials that have been tried on smaller groups of people and then maybe phase 2 trials and then being used. Some of us know about cancer drugs that haven't actually gone through all the phases, but there is some consensus that they may help, and yet people clamor for them across the country and across the world, asking for those medications to be released so that they can be tried to see whether their cancer can be held back. Having said that, these vaccines have gone through all 3 phases before being released to the general public, albeit we know that the phases overlapped rather than the phases going in sequence, which would normally have taken a much longer time. But we know that this was a response to a global pandemic. So the money and the government support and the support of scientists worldwide who are also sharing information made it possible for us to receive the vaccines at a very quick rate, but also in a safe form. We know that so many people worldwide have been vaccinated, and in the UK, we've already heard that over 20 million people have been vaccinated, and we haven't had any serious side effects or major effects that have come up. But the others that we have heard, like for instance, there have been reports of deaths in Korea and in Denmark, as I said, are being investigated to see whether there's a causal relationship. So we are watching this space, but we are encouraging everyone who is offered the vaccine to consider it. We as health professionals, I have had my vaccine. I know that most of the speakers here would have had their vaccine. Thank you very much.
Thank you so much. Thank you. Yes, thank you very much for that very concise, to the point, clear presentation. And I just want to make a few comments. I'm very glad, Dr. Usuyanama, that you brought up this distinction between what is causal. You see, so there's a difference between causal and there's a difference between a correlation. A correlation could be a relationship that could be an association or something that could be negatively associated or positively associated, but not necessarily a causal. You see, so sometimes when this sort of information is released, I think people just automatically assume that, oh yes, it's causing, it is the vaccine that is actually causing the blood clots, and it's not necessarily. So when Dr. Dorcas was talking about it's still being studied, and they know that it is not at this point a cause. That's what it means. They have noticed a pattern, which is what could be a correlation, but not necessarily a causal. Causal is a very serious thing, which means directly you give a patient the vaccine and it can cause. At the moment, it's too early to say. And if they think that it is not enough for the vaccines to, for them to stop giving the vaccines and to continue giving those vaccines whilst the studies and the trials still go ahead, then I think they're thinking more around the correlations and not necessarily causal. Dr. Usuyanuma, thank you so much for that. And with that, I hand over to Mrs. Samantha Prosser. Thank you.
Thank you. So the next speaker I'm going to introduce is Dr. Jasmine Leonce. Jasmine, I've come to know her. She is part of the One2One Mentoring Network. So Jasmine is a consultant obstetrician and clinical director for obstetrics at East and North Hertfordshire NHS Trust. She has a governance role in One2One Mentoring Network. She's a member of her Trust BAME group and co-chairs a BAME operational group in maternity. She is led on improvement pathways with the lead midwife relating to COVID maternal morbidity reports, which has led to the production of operational guidance for BAME women within her local maternity system. She's also produced a video of her experience of having the COVID vaccine and has participated in webinars related to COVID vaccination in the BAME community. She is also a link contact for pregnant women and staff seeking advice on COVID vaccination within her trust. Jasmine, welcome. Your question is, what vaccines are available and what is the science behind the AstraZeneca and biotech vaccines? Thank you.
Thank you, Sam, and lovely to be part of the discussions this afternoon on a very, very important topic about the COVID-19 and the vaccines. You may all recall that in December, and I think it was the 8th of December, and Margaret Keegan, she obtained the first vaccination with Pfizer vaccine, and that was an historic day for us. And I think Sedina alluded to the fact that we now have over 23 million people who've been vaccinated in the UK, and worldwide over 200 and something million people have been vaccinated. So it's really taking off, and it's good to see the numbers increasing. I think Sedina also mentioned that there are lots of vaccines being developed at the moment. I think over 200 when I had a look yesterday, even being developed. We're familiar with probably about 7 vaccines at the moment, but I'm just going to concentrate on the differences between the AstraZeneca and the Pfizer vaccine. I'm going to try to keep it simple because I know some of us hate biochemistry, and so I'm just going to stick to basic terms, so do bear with me. So what are the principles of vaccination? So essentially, with the vaccine, we're injecting either virus fragments that are actually injected into the body, or via the vaccine, we're given instructions to produce fragments that are representative of the coronavirus or any particular virus. The idea being is non-threatening, so we'll not be actually infected with anything. Some people, that's one of the myths. Again, probably people are thinking that they'll be actually, you've been given the virus per se, it's not a live virus, etc. And we'll discuss that as well. So once we given the vaccine, then the body will then recognize these fragments as being foreign elements in the body. And then our body will then mount an immune response to the fragments. And this will then subsequently boost our immunity. It creates memory so that when we're actually exposed to the actual virus in the future, our body can mount a prompt response that will neutralize the effects of the virus and ultimately prevent severe illness, prevent the illness altogether, and certainly death. Next slide, please. But to understand how the vaccines work, it's good to know the structure of the coronavirus, and Dr. Mike, discussed a bit about it in his introduction. And then we can concentrate on the elements relevant to the vaccine. So this is just a picture of the coronavirus, as you can see. And on the outside of it has these spike proteins, which are called glycoproteins, very important. And the coronavirus is an RNA virus. So you've got RNA on the inner side and other envelopes surrounding the coronavirus. Next slide, please. So what happens when you actually become infected with coronavirus? Yes, so what happens? So this is another diagram of the coronavirus. And as you can see on the inside, you've got the sort of spike protein gene. And on the outside, you've got these little red little bits, which are the spike proteins that I showed in the previous slide. So the coronavirus would enter the cells, and what it tends to do, it binds to receptors on our cells, and then it invades the cells, our cells, and it essentially takes over in terms of all the production of proteins. And it's like an army, and it wants to replicate and duplicate itself. And that's how we end up getting all these infections. So that's what the coronavirus does. So what the vaccines are meant to do, they actually try to replicate these spike proteins that are on the outskirts of the virus, so that the body can then mount that response to these spike proteins. So that's essentially the principle in terms of how the vaccines work. And I'll just talk about the differences between the two. Next slide. So in terms of the types of vaccines, so we talked about the messenger RNA. So essentially the nuclear code being given instructions to produce these spike proteins. And that's the mechanism of action for the Pfizer-BioNTech vaccine. Other vaccines, Moderna vaccine, which is also approved, not yet being used in the UK, but approved. There's a Sputnik as well, which is the Russian vaccine that you may have heard about. And there are other messenger RNA vaccines being looked into at the moment. So this uses a synthetic messenger RNA. So just to be very clear, so it's not actually from the virus itself, it's synthetically, so it's engineered, manufactured. So that's for the Pfizer-BioNTech vaccine. The other type of vaccines are the viral vector vaccines, such as AstraZeneca, you've got Johnson & Johnson. These are examples of the viral vector vaccines. And the principle behind this is that a deactivated virus, such as the adenovirus, or what causes the common cold, is actually used with DNA. So you've got DNA representative of the coronavirus sort of inside. And then that's actually, again, injected, and then will then ultimately lead to messenger RNA being produced. And then you have leading to the production of the spike proteins. Okay, and again, once the spike proteins are produced, that could be recognized, the body can then mount a response and then hopefully get rid of the virus. The third type of vaccine is called a protein subunit vaccine, and Novavax is an example, Sanofi and the GSK vaccine, these are examples. And that protein subunit is actually delivering these spike proteins themselves. So that's the third one, and that's probably more newer ones at the moment. And so that's the sort of mechanism of action. And again, you have the spike proteins being generated, and the body can then again mount a response, again, these spike proteins. Okay, next slide, please. So this is an example of what the vaccine would be looking like for the Pfizer, which is a messenger RNA. So you can see in the red in the middle is a synthetic messenger RNA genetic code. And that's surrounded by a lipid nanoparticle that surrounds the messenger RNA. Next slide, please. So you can see at the top here where you have the synthetic messenger RNA coming into the cell, and that goes into the cytoplasm. And then you have the nuclear code given the instructions to produce these spike proteins, and you get fragments of spike proteins that are also generated, and these then migrate to the surface of the cell. And you can see that they're visible, and the body is then going to recognize these spike proteins as foreign. And again, you have that immune response being generated and boosting infection, and then rebuilding immunity that way. So that's the mechanism of action for the Pfizer-BioNTech vaccine. Now, when you look at the AstraZeneca vaccine, which you said is a viral vector vaccine, So this is sort of DNA inside the adenovirus. So things come from chimpanzees, and that's used. So that's inside of the virus, and it's a spike protein gene that's going to then code again for messenger RNA to actually then produce a spike proteins. So if you go to the next slide, we'll show how that works. So again, you can see at the top, so you've got this, again, the DNA inside, the vector, so the adenovirus vector actually entering the cell. Then that then goes into the cytoplasm, and that makes its way to the nucleus of the cell, which is where all the sort of protein instructions, are given. The vector releases its DNA into the nucleus, then transcribes that into messenger RNA, and then the messenger RNA goes back into the cytoplasm. And you can see that, and if you go to the next slide, then that messenger RNA, again, it more or less reverts back to what the Pfizer vaccine does, again, making spike proteins. And these spike proteins come to the surface of the cell and again are recognized as foreign, and the body is then going to mount immune response to these spike proteins, again, to generate either to get rid of these cells. Next slide, please. So this is an example of a vaccinated cell. You can see on to the right of the screen, and you've got your B helper cells, your T helper cells, all getting involved because you have these spike proteins on the vaccinated cell, and they actually can attach themselves to these spike proteins. You have antibodies then being produced, and again, these antibodies as well can then counteract and neutralize these spike proteins and preventing that virus from binding to other cells to get infected and ultimately severe infection. So stopping coronavirus, same, you've got, again, activated killer T cells, again, recognizing these infected cells if you get coronavirus now. So if you get coronavirus, you have infected cells, and then you have these spike proteins, and then the body is ready now with coronavirus, if you do get exposed, to actually, again, counteract that response. You get a prompt response because of the vaccine. Okay, next slide, please. So again, this is showing if you have infection now with coronavirus, and again, these spike proteins on the outside of the cell, the antibodies are now ready, and to again neutralize these and obviously ultimately get rid of the coronavirus. Okay, next slide. So this is essentially how the vaccines work. And Selena talked a bit about the virus and efficacy. So we know the vaccines are meant to be up to 95% effective, as we know. And she talked as well about the dosing, 2 doses, ideally 28 days apart. But there's a lot of evidence in the studies are showing that the 12-week interval is obviously as effective, over 82%, etc. And the full protection against the Selena didn't mention, it would be 7 to 14 days after you've had both doses, but even after your first dose, the body is going to take at least about 2 weeks to start mounting that response. And you could actually have protection even after the first dose. And she also mentioned that the Johnson & Johnson is normally a single dose vaccine that's been developed. And the key message to say again, and to echo what Selena has said, is that all the vaccines are effective. And you would have heard in Europe talking about people refusing the AstraZeneca vaccine, waiting for another one. They want the Pfizer, and whatever vaccine we're offered, we should take. They're all effective against severe disease, against possibly getting the virus as well. If you do get COVID, it might be that infection would be very mild, but the key thing is that the vaccines would prevent us from getting severe infection and obviously ultimately hospitalizations and then death. And to echo what Lynn has said, again, is about social distancing, acknowledging that, wearing masks, similar things we need to do, and even being vaccinated to know that you may still transmit the virus. So just remember that you can still transmit the virus. So again, we still need to adhere to all the environmental precautions. Okay, so thank you very much. Thank you.
Thank you, Jasmine. Once again, another very thorough response. And I think what I as I listened, I hadn't even realized that we had yet another a set of vaccines. So mRNA, which is the ones we know about, the viral vector vaccines, but the protein subunit, now that I didn't know about. And thank you for taking the trouble as well to really give us the breakdown of, you know, giving us diagrams and everything else of the you know, how it's all, how the coronavirus impacts on the cells, etc. And we are very grateful, so thank you so much. I'm going to pass pass back to Susan.
Thank you very much, Sam. And so we're going to go to our last speaker, and I would encourage everyone to hang around. We are running over, I think we'll probably be maybe 50 minutes over, but it's worth it, because what we're going to do is to bring all our speakers and ask them some questions that maybe it may not have come out in during their presentation. So please be patient with us and hang around. So our last speaker is going to talk about something very important. So as a response, as a one-to-one, our response to the whole issue around the COVID-19 hesitancy, we decided to look at the vaccine hesitancy in our own network, contacts and subscribers. So Dr. Ivy Fortune Glavy is going to be giving a summary of those results. It's just the first phase of the results. The results are still ongoing. The research survey is still ongoing. But what we've done is just look at what we have so far, and then just taking a summary of so far what the picture is showing. So I have known Dr. Glavy since primary school, throughout primary school, secondary school, and medical school. She's actually one of the ones that have, and I would say the longest in when it comes to my friends and colleague as well. So Dr. Fortune Glavy is the program director for One2One Mentoring Network. She's a visionary leader, mentor, an amazing poet. I have heard her, artist, author, creator of recipes, clinical entrepreneur, fellow, and dental surgeon. After some time at the University of Ghana Medical School, she completed her dental studies at King's College London. She is passionate about dental prevention and research and has completed her master's in community dental practice. She was also a clinical research assistant at King's College London. So over to you, Dr. Glavy. I'm looking forward to these results. Thank you.
Thank you, thank you. Thank you for having me. Can we have the slides, please? So this is basically talking about the research by One2One Mentoring. Next slide, please. So I'm going to start the results with a quote from Age Organization UK, and this is what is stated. At the beginning of 2021, the Office for National Statistics discovered that 85% of white people accepted the vaccines, compared to 72% of Asian people, and only 49% of Black people. It is against this background that One2One Mentoring Network decided to explore COVID-19 hesitancy in Black and minority ethnic people. Next slide, please. So the hypothesis, so basically why? What is our why? Why are we doing what we've decided to do? It is to find out the reasons why people from Black and minority ethnic community are hesitant in taking the COVID-19 vaccine. Next slide, please. So what was the material and method used? So One2One Mentoring, some of the key partners formed the focus group and met and designed a questionnaire, which was distributed to our network over a 4-week period. Next slide, please. So for descriptive purposes, the results will be analyzed quantitatively and qualitatively. Quantitatively, we'll be looking at key cross-reference points. Qualitative, normally just to find out some of the statements or comments made and summarize it. And the second qualitative is just to hear from Black Africans who will have it or have not had it. Next slide, please. So these are the results. So over the 4-week period, 93 people took part. And out of the 93, this is the breakdown according to ethnicity. Of the 93 people who took part in the survey, 57 were Africans, 5 were Caribbean, any other Black were 5, Asians were 12, there were 10 white people, 4 people did not state their ethnicity. Next slide, please. If we look at the ethnicity of the people who have not had vaccine or are still awaiting an appointment, of the 40, 19 were Black Africans. Out of those 19 Black Africans, 10 of them are undecided or will not have it. The other breakdown, Caribbean 4, any other Black 2, Asian 6, white 8. And not stated again is only one person who did not state their ethnicity. Next slide, please. Now the question is to focus on the 10 Black Africans who decided they will not take the vaccine or are undecided. Out of the 10, 5 are undecided and 5 will not have the vaccine. Interestingly, all of them are women. And when you look at the age range, 8 of them are in the 40 to 58 range. Occupation-wise, 1 is a student and not employed. Of all the 10 people, 8 have had other vaccines, including their families, since adulthood. Next slide, please. Now, this is the very interesting bit of it. Now, we all want to know the reason why there is this sort of vaccine hesitancy. Now, generally, it is not because people do not want to be vaccinated. We all have had vaccination as a child, or if you are traveling abroad, you are vaccinated. In certain places, you've got to prove you've had a vaccination before they will even allow you to travel. But in this case, it's mainly because it is COVID. And also there is that sort of lack of trust in drug companies, government intentions and researchers. I'm sure you've all heard about the Tuskegee trial, what happened in America, and that has caused a lot of lack of trust in all this organization and everything that's happening in the world. Next slide, please. Another reason that was given by one of the participants is that they feel it may alter their DNA, which is quite concerning, not surprising, especially if you look at all the research that has been done in the past. Next slide, please. Of the people who might change their minds, so it means people are willing to take the vaccine, but they would prefer there should be more testing on people or more testing on Black and ethnic minority. Others feel there needs to be more education on what it is all about, and that will sort of force them to take the vaccine. Next slide, please. So qualitatively, really what we are looking at are some of the reasons that people give. So in all, again, I must stress again, that sort of mistrust, and also the fact that the inequality that people have experienced, especially between Black people and white people. And also some people may be phobic, they may be scared of the needle. But there was one interesting comment or one interesting result that states that Black people do not have a genetic disposition towards viral infections. Next slide, please. So the comments from those who've had the vaccine is basically that they feel that the reason why they've had the vaccine is they feel it to protect them and the wider community. And also most Black and ethnic minorities are frontline staff. And so that was the motivation for taking the vaccine. Next slide, please. So what are the implications and conclusion? So basically the conclusion is that people are willing to take the vaccine if there is more education out there. And throughout the research, it's just a small minority of these people from the Black African community, about 13%, who will not take the vaccine. And I'm sure with more education, people will be willing to take the vaccine. My own take on that is, according to the CAB model, where K stands for knowledge, A, attitude, and B, behavior. Knowledge is power. If people are given the knowledge, it changes attitudes and it changes behavior, and they will be willing to take the vaccine. Next slide, please. Thank you very much for listening. And we also want to thank all the researchers, key partners, participants, and contributors to this research. We also want to thank the working group led by Prof. Amaka and Dr. Susan Oze, who was the facilitator. Thank you for listening.
Thank you. Thank you very much, Dr. Glavy, for that. And so just to clarify just a few things. So there's just, in terms of the study, I think we turned it around. So last year after the pandemic, the first wave of the pandemic, and there was a study looking at exploring vaccine hesitancy in the different ethnic groups. And it was actually 72% of people from the Black community had said that they were either they were either not willing, very unwilling or unwilling to take the vaccines, and then 49% in Pakistani or people from the Pakistani or Bangladeshi community. So it's the other way around. And then just a little bit about the Tuskegee. Now, the Tuskegee study was I don't know, it was a syphilis study in African Americans in 1932, which initially involved 600 Black men, 399 with syphilis, and 201 who did not have the disease. The study was conducted without the benefit of patient consent. So there was a whole scandal. They had to be reimbursed. There was a whole scandal around it, in the sense that they were given a reason or an explanation for the study, but it wasn't the right explanation. And also the study was not supposed to, I think there was a limited time that the study had to go on for, and it went on for 40 years. And some of these men had a lot of complications. And then particularly if it was a syphilis study, and yet they included people who did not have syphilis at all. So all that has led to some of that mistrust around vaccines that we see now. And this is what Dr. Glavy was referring to. All right, so now what we are going to do is to bring all the panelists. So Marvin, if you can all the panelists please take off your videos and come on. What we are going to do is that because we are really looking at the chat, and I think that I'm hoping that most of the questions have been answered by all our speakers, but we felt that there are some other questions that we're going to still ask, and it may be just a revision. It's just reiterating what everyone has said, and hopefully for some of you that may still have questions, hopefully just going through asking the speakers to answer some more of these questions, your questions might be answered. So over to you, Sam.
Okay, so the first question, which we are going to ask Dr. Ivy, is why, based actually on having gone through the survey, why is there a reluctance with vaccines uptake in the BAME community? Dr. Ivy.
Thank you, sorry. Can Dr. Ivy, can you please put your video on, if you can? So.
Hello.
Hi there.
Hiya.
Yes. So did you hear my question, Dr. Ivy?
Go ahead.
Oh, okay. So it says, why is there a reluctance vaccines uptake in the BAME community? And this is me thinking about that you've just gone through what you just did with the survey that we've had. Why is there a reluctance, do you think?
Well, because of needlephobia, the mistrust, as I've already mentioned, and then government and inequality among Black people and white people in this country. So it's basically all that has made people to be scared. So they just need more knowledge. Thank you.
Okay. Thanks, Dr. Ivy. Back to you, Susan. Susan, you're on mute.
Why am I doing this today?
I think best not to mute yourself.
Key mistakes. I think I'm going to leave it on. So the next question is to you, Dr. Mike. Does the vaccine alter DNA? Because, you know, I'm sure you saw how Dr. Yasmin had put all these lovely fancy, you know, pictures on there. And then when you see that little nucleus, yeah, which has got DNA, and you're seeing all these things going around it, you know, should people be worried that it's really going to alter DNA? If you can just shed some light on this. Thank you.
Yeah, thanks very much, Dr. Susan. From the pictures that Dr. Hazel shared with us, it was very clear that the mRNA does not actually enter the nucleus of the cell. It stays within the cytoplasm, performs its function, and is completely degenerated soon after that. And I think that is one of the reasons why it requires very intrinsic storage measures at minus 70 degrees centigrade, because the mRNA disintegrates very quickly if it is not kept at that low temperature. Thank you.
Thank you. It takes me back to biology, isn't it? If I'm sure you all remember the simple cell, isn't it? That cell with a cell wall, and then you've got the cytoplasm, and then you've got that little nucleus in there, and then you've got all the DNA, lovely material. Yes, so we know that it doesn't actually go in. It swims around and then goes back to the surface of the cell. Thank you very much. I hope that has reassured some of us who are very concerned about the virus altering our precious DNA. Over to you, Mrs. Prosser.
Thank you. So, Sedina, I have a question for you. These are all questions that have been compiled anyway, because we've had various things sent in. So it says, was the vaccine tested on people from the BAME community? Could you answer that?
So about 10% of the people in the trials were from the BAME community. So a mixture of Black Africans, Asians, and other minority ethnic groups. So yes, it was.
Which is brilliant, because I think the black people from the Black community, about, is it 3 to 4%?
Yeah, it's quite a high percentage, and actually a lot of them were healthcare professionals. So these trials for these vaccines are some of the largest trials that have ever been seen for vaccines as well. And I think that's worth people knowing that a lot of vaccine trials are actually quite small. With the AstraZeneca and the Pfizer, between the two is over 80,000 people were actually in the trials. So it's a lot of people. And people also need to remember that the trial data is still being monitored, and as we're all having the vaccines as well, which is why it's important, as one of the speakers, I think it was Dorcas, that mentioned the yellow card system, because we're all responsible for building the picture of the safety of the vaccine. So people do need to report any incidents that they have, because it's almost like the trial is continuing as the vaccine. It's the post-surveillance phase of the trial, and it's the post-marketing, although it's not being marketed, but it is part of the clinical trial sequence. And so it is quite important that information is reported back so that we have an accurate picture. But yes, you know, large numbers of patients, lots of Black people, and lots of Black people, like all of us who've had it, have had it as well. So I hope that instills some confidence in our Black community.
And we are alive. I think there's a very nice joke here that it must be as usual, my cousin. She said, she's saying something here that she has nidophobia, but she rather preferred to live. So she went for the vaccines. Good on you, Mrs. Ajay-Owusu.
I have a little bit of a joke that I tell people that I've been speaking to, and they kind of go, oh, I'm not sure. And I say, you know something, if our community continue to be hesitant, it's going to come a time when the only people that haven't been immunized are going to be our community. And what's going to happen then is we're going to see COVID return into our community. And then it will well and truly be a Black person's disease. And then we might really have a vaccine made just for us. So we just need to, you know, have it when everyone else is having it, protect our communities like all the other communities, because we could be creating a situation that we really don't want. Okay, so that's something that people need to bear in mind.
Okay, thank you very much. Dr. Vaccination, I'm coming to you. Why are children not given the vaccine, and will this happen in the future?
So I think there has been a lot of discussions about this, but what we know so far about our experience in pediatrics is that the children were the least affected during this whole pandemic. The incidence rate and case fatality rate for children is very low. And as a result of this, we have to balance, obviously, we have to prioritize vaccination of at-risk groups. So those would be the elderly, above 50 and above 65. And obviously the rollout for children will be probably the last phase because of this main reason. And second of all, I think there have been some reports of those children with neurodevelopmental sort of difficulties and impairment that have shown quite severe disease. And this is multifactorial. It's not just because of chronic lung problems or chronic respiratory symptoms, but we don't quite understand why they are more vulnerable than the others. And the discussion and analysis of the pediatric population for those that will eventually be at risk and therefore when the vaccine will be rolled out, they will be prioritized. They will likely be the first group of those that will be immunized. And this was discussed during the last British Pediatric Allergy, Immunology and Infectious Disease Group teleconference about 2 weeks ago. So apart from that, obviously, we know that the clinical trials have been rolled out and have been done for people from 18 up to 65 and older. So the under 16s have not been necessarily included in most of these clinical trials. For those who have had experience in research, and we know that the medical ethics and recruitment of children for clinical trials is very, very difficult and challenging. There are obviously reasons to suggest that these are safe for children. And in fact, the under 20s and over 18 have been immunized for those who are at risk. That's been offered to them already, especially from the group that I have just mentioned.
Thank you very much.
Just to add to that, we actually are immunizing children between 12 and 15 if they've got severe neurodegenerative disease and are in a home or in an area where they're at high risk. And that has been done with no problems at all as well. So that is going on. And
I know that there is a trial going on, isn't it? There is a trial. There's a trial from quite young children starting, very recently. Thank you very much. Sam, over to you.
Okay. So Dorcas, this next question is for you, a little bit controversial. So it says here, so I'm saying, I've heard that the vaccine may be linked to the mark of the beast in the Bible. Could you give us any sort of background around that? And I guess it falls under myth because it just does. So can you tell us a little bit about that? Thank you.
Okay, so the mark of the beast, as the Bible puts it, is a mark that will be received on the forehead and on the hand. This is something that is in the future that will prevent people from being able to buy or sell if they have not received the mark. So it's going to be something that people are going to be required to have if they want to carry on living as normal. However, as we have already heard, when the vaccine doesn't have anything in it, we heard that it doesn't have any tracking system and it's put into the arm, it doesn't leave anything visible on us long term, and it's definitely not on the hand or on the forehead. So this is really to allay the anxieties of those who think that for some reason this vaccine has some link to, the Antichrist and what people are afraid about. Yeah, so that's what I would say.
Thank you, Dorcas. Thank you.
Thank you very much. And I'm coming back to you, Dr. Vaccination. We are hearing that we may need to be wearing double masks. Is this justified?
So I think this has come out because in the press, is it Dr. Fauci, who's the New York, the lead for the infectious disease rollout, of COVID response in New York, mainly and in America, he has suggested that it's very sensible to actually wear double masks with regards to prevention of coronavirus transmission. But I think based on this, the CDC has published an article to say that in as much as, yes, you can protect yourself because it makes sense. You double up the protection. And especially if you're wearing surgical mask underneath and then a cotton mask on top, then potentially that can increase the protection much more. However, I think they have highlighted that when you double mask, you actually influence or affect the seal of the mask underneath, because you can dislodge it and also you become uncomfortable and you tend to take it off more frequently to try and inhale and breathe normally. And I think that is the problem. We can be led into a false sense of security that actually the fact that we're wearing double masks, we can touch our face, we can go close to people, and we know that you can have a very, very small risk of aerosol transmission or airborne transmission. And with regards to this, you can come into close contact with people if you've got a leak in your mask that can escape. So airborne virus can escape and you can infect in that way. So effective use of a mask, safe social distancing of 2 meters onwards and more are proven to be effective. Double mask, if that's a preference, if you can maintain it with hand washing after you've touched the mask or after you've handled it when it's contaminated, then that's better than nothing, better than no protection at all. But I think it's more the effective use of all these measures. It's the proper masking, doffing or taking off that mask, hand hygiene after you've touched surfaces. Those are the key things that we need to do. Double masking is a preference. We're not against it, but just make sure that it's well sealed if you do have to use it.
Thank you very much, Dr. Ventilacion. Over to you, Sam.
Okay. Dr. Ventilacion, I think I still have got one more question for you. So it says here, so can I still transmit the virus if I'm vaccinated?
Yes, I think Dr. Michael Gundelli and I think Sedina has, or even Jasmine, have alluded to that yes, after you've been vaccinated, there is a chance that you can still catch the virus, that you can still be infected with the virus. But what we know so far is that you will not die from the virus. That's the first thing that we would like to say, unless there are other extenuating circumstances that can influence that. And we know there's no 100% statistics for everything. We are not necessarily a number in the statistics. We are our own, entity. So chance, fate, luck, destiny happens, but based on evidence, and we're talking about how many, 23 million people already being vaccinated all across the world, the safety and efficacy is very good. So yes, you can get infected from it. The chances of you dying and having severe disease, mortality is significantly reduced. And there is some evidence now that there is 70% reduction in your ability to transmit the infection further. So when you've got the antibodies, it somehow controls the infection much quicker, and to a degree that maybe your titers or level of viral infectious titers within the bloodstream are much lower compared to when you do not have any protection at all. So for all those reasons, definitely, that's the best choice that you can ever give to yourself, to be vaccinated.
Thank you.
I hope that answers your question.
Yes.
Thank you.
I think there's a question here, and this is from Linda Ajayewusu. Linda, let me bring it up. Do I need to keep my mask on all day? And I think perhaps, maybe Dr. Mike, if you answer this, please. Do I need to keep my mask on all day if I share an office but sit at least 2 meters apart?
Yeah, thank you very much. I think that's a good question. If there's opportunity for clear social distancing of at least 2 meters, then I don't think it is necessary to keep the mask on all the time. But of course, if there are mitigating circumstances when that distance cannot be kept, then okay, it's important to put on the mask. Because like Dr. ventilation said, if you keep on the long period, there's tendency to become complacent and you keep touching it and keep removing it and wiping your nose and all those kind of things. So and it becomes less effective. And especially if you are in the same bubble with the same set of people over a prolonged period of time, then you are probably formed a bubble anyway. And then, of course, one person is not likely going to infect somebody else. Thank you.
Thank you. Do you want to add anything, Dr. Ventilacion?
Yes, thank you. I would just like to add that there are other factors. I think we did stick to social distancing, hands and face protection. But there is also the factor of ventilation, so airflow in the room. So it's very important to see whether they're in a crowded space, whether that's been health assessed by health and safety. So if that has been sort of adequately risk assessed, then I would say that you can remove, in fact, if you've got a perspex screen or if you're back to back from one another and you've got good ventilation in the room, there is a possibility that you can have breaks of taking that mask off. But we always think about that the virus is unseen. The more that we block the entry points, which is the nose, the mouth, and the eyes, the higher the protection that we are giving ourselves. And it's vice versa. You know, you're not sure that you're just protecting yourself, you're also protecting your colleagues. You could both be asymptomatic carriers of the infection at that time. So it's best to wear it, but the most important thing is not touching it constantly. So if you can imagine that the virus is hanging around, you know, and it's circulating, if most of the time it's heavy, so it drops in a projectile manner up to 1 to 1.5 meters. So if you're facing that way, the droplet will likely fall on your desk, and the same for your colleague at the back. But if they're on the side, there is a chance that your surfaces can be contaminated. So we're not just talking about the mask, but it's how you integrate with your environment, how you hand hygiene after touching surfaces, and how you constantly ventilate the room. So the key thing is keep it at arm's length, block the entry points, wash your hands as soon as you've touched any surfaces, especially when you touch your mask. Because if you think that the virus sticks or the droplets stick to the outside of your mask, you touch it, put it down, don't wash your hands, but then, you know, you eat and you wipe your, you know, all of these things can lead to transmission without us knowing it. So the mask is one part of the story, very important, but it's all the other aspects that come together that we've got to sort of really, really pin down and sort of put into practice. Because once we understand that, we know that, you know, we can be protected as best we can.
Yeah, I think there's something about being intentional, isn't it? I mean, I know that when my secretary hands me, I hand my secretary the dictaphone, I wipe it, I actually cover it with that disinfectant towel. Then when they hand it to me, they are wiping it. Even when so it's not me being paranoid, but I think just being intentional about how we are just using the whole public health knowledge advice in terms of washing hands and keeping that safe distance and then wearing our mask and also changing the mask, isn't it? Sometimes we have the habit of putting it down and then we bring it up, and we all do it. So just being intentional about it. Okay, so the last question is going to go to Dr. Yasmin. And what advice would you give pregnant moms? I know we've tackled it, but it's just one of those things that we are just reiterating the messages. Can they accept the vaccine? So can you deal with pregnant and breastfeeding moms, that sort of thing?
Yes, so so in terms of the trials so far, as we know, we've not actually done trials in pregnant women. So currently, we know that the advice is to not have the vaccine if you don't have any sort of high-risk conditions, such as, you know, for example, renal disease, cardiac disease, or if you're not in a patient-facing role. So some of us, you know, some women might be working in an NHS or the high risk of exposure to COVID, and then we advise you have the vaccine. So there's nothing for us there's nothing to suggest that the vaccines are unsafe, because obviously pregnant women have vaccines such as, you know, flu vaccine, whooping cough in pregnancy. So there's nothing to suggest that. There is a study going on at the moment, the UK obstetric surveillance system. So that's actually, you know, collecting data on women having vaccines, we would have some more information around that. And for pregnancy, for breastfeeding as well, there's nothing to suggest that women cannot have the vaccine, if they're breastfeeding or in the postnatal period. So the advice generally is not to have it. If you've got high-risk conditions or patient-facing roles, then you can have the vaccine. Yeah.
Thank you so much. And you know something, I also want to say, thank you to the speakers, but I also want to say thank you to the participants. You've all been very attentive. You have all put in very good questions in the chat. And we're really hoping that whatever has been discussed has been able to, particularly for those of you who are maybe slightly undecided or have decided that they don't want to take the vaccine, maybe this has contributed to a little bit of that evidence, a little bit of that information for you to make your own decision as to whether you want to take the vaccine or not. So just before we wrap up, I want to just go around and ask our speakers whether they've had their vaccines. This is the fun round. So I've had my vaccine, and I had it, for me, it's just this strange reaction. You will laugh. When I take the vaccine, 6 hours after I've taken the vaccine, I feel as if I've taken an antihistamine where I'm feeling so sedated. I feel drowsy, and it's a kind of nice drowsiness. It's just one of those things that I kind of think, at first I thought it was a coincidence. And then when I took my second vaccine 2 weeks ago, I had the best sleep of my life. That is me. I mean, one of the side effects is supposed to be tiredness, but I'm just so hyperactive that perhaps I don't feel I'm tired, but I definitely know that I am drowsy and I sleep. I have reported it. I've reported it on this, notify the yellow card, because I haven't seen it. I've only seen tiredness, but not seen sleepiness. But I don't think I'm the only one that's had that effect, but that's the only effect that I have had. Sam, have you had your vaccine?
I've had my vaccine and I'm waiting to have my second one. I think I just remembered feeling quite fluey, but nothing that, I mean, as quickly as it came, it went. And I remember ringing up Sadina and talking about it. And I think the theory is that, listen, if you're feeling uncomfortable, it's working. That's it. So yeah. So Lynn, I'll hand over to you.
Yes, so yes, definitely, I've had my vaccine, and I will remind everyone that when they take their vaccine, make sure that you have a good meal and that you hydrate well and that you sleep well the night before, because I didn't do any of those, but still jumped in and had my vaccine on the 22nd of December, that fateful day. And I felt a little bit dizzy because I was probably imagining all of the mechanisms that Jasmine has highlighted about vaccination. Being a doctor, you sort of overthink these things. I'm thinking my immune system is trying to fight and recognize this virus. For all those reasons, I asked for a glass of water, and either side of me, the 90, 80-year-olds were jumping out of their chairs within 5 minutes, whereas I still had to hydrate to feel a bit better. So I've had my vaccine. My husband, who's part Caribbean, so he's Mauritian, British Mauritian, mixed race. He's also had his vaccine, and he was running. He was on a run the following day. I had a whole day clinic the following day. So I felt really good for it. So yes.
Thank you. Sadina?
Absolutely, yes. I've had both of my vaccines. I was extremely exhausted from setting up the clinics that I just slept like a baby the day I had my first one because I was so tired anyway. So didn't notice. The second one, I had a bit of the lead arm. And I remember, again, I was absolutely exhausted. And I woke up and I thought, oh, I forgot to take my paracetamol. So normally I say to people, before you have your jab, take some paracetamol, have some paracetamol for about 24 hours after. But I didn't take my own medicine, literally. And I came home from work, I was absolutely shattered, fell asleep, had to wake up and take it, and then I was fine. So there you go, that's me.
Great stuff. How about you, Dr. Dorcas?
Okay, so I've had my vaccines. The first time I had a sore arm, maybe about 8 hours afterwards, which sort of passed by the following morning. And the second time, I just felt a bit achy and fluey and rested a bit more. And then by the following day, I was back to myself.
Good.
Dr. Yasmin, how about you?
Yes, I have just completed my second dose. I think it was on Tuesday. First dose, bit of a headache, sore arm. And then when I went for the second one, I was literally bragging, saying, "Oh, I've had no side effects." So the other bit of advice is that you take the paracetamol before you go for for the vaccines. I did all that, and then I was like, "Oh yeah, no side effects." And then the next day, and then I felt a bit chilled, a bit of chills the next day. But yeah, that was it. I was fine afterwards. So.
Thank you. Dr. Ivy? All the ladies first, gentlemen before. Dr. Ivy, how about you? We want to hear about your experience.
Oh, I'm waiting patiently. We are frontline, and they've given us, waiting for an appointment to take it. My partner took his today, so I'm also looking forward to taking mine. So yeah,
Great,
I'm waiting for my appointment patiently. But this as today has convinced me that I should go for it. Being a frontline person, I think it's very important to protect myself and the wider community. Thank you.
That's
I
excellent.
don't know where you are, Dr. Ivy, but you can come and see us tomorrow. We'll immunize you.
Really? Okay. All right. How do I book that? Through you?
If you get my number from Samantha, because as a frontline worker, we can't leave you unprotected, really. So yeah, it's important.
Okay. All right. Thank you. I'm taking up that offer. Definitely. We'll talk after. Thank you.
Dr. Mike?
That's what they call corruption and bribery.
No, she's in the priority category. So.
Have you had your vaccine, Dr. Mike?
So, I mean, I couldn't take my own vaccine on time because on the Christmas Eve, I tested positive for COVID.
Oh,
So
okay.
I had my self-immunity from that. So I had to wait another 4 weeks to take my first dose.
Fair enough.
I had a bit of aches on my arm for about 24 hours, a bit tired, a little bit more tired than normal, but I was able to do my normal routine clinics all along. And then gradually, within 48 hours, I was totally back to normal. So I'm just waiting for my second dose now.
Thank you. We are very much aware that this has gone on beyond the time that we expected it to go, but obviously we have an attentive audience, which is not surprising with all that very lovely information, very informative information that has been presented by our knowledgeable panel of experts. Thank you very, very much. We are now going to just summarize the main points, and then that will be it. Sam, I think I'll give that to you. If you can just, do you have any last summary or anything from the doctors that you introduced that you think is any point that stood out for you?
I think all in all, it's again, a huge thank you to everybody, and I think we've learned so much. Certainly, from Dr. Mike kind of explaining to us that this it's something that people are thinking that it's a BAME illness, and that we do have to look after ourselves as well. Coming from that community, it kind of sits with us to make sure that we look after ourselves. And use the NHS well. From Sedina, I guess the big message was, get out there, go and get vaccinated. Yes, it was produced very quickly. The vaccines have been produced very quickly, but so far so good. And there is a we can see the reduction. I think for me, that's the most exciting thing, is the reduction in serious illness and hospitalization. So that's very good. And from Jasmine, quite frankly, making it much easier for us to understand what goes on with the virus when it enters the body. So those are my sort of 3 take-homes.
Takeaway.
Yes, exactly.
Excellent. For me, I think Dr. Vaccination, very poignant, this very clear messages, clear, simple. Wash your hands, wash your hands, wash your hands. cover the face, and maintain safe distance. That was very clear. We've heard these messages, but they are so effective. And that is why we keep hearing them over and over and over again. And even when you've had your vaccine, it's very important to remember these very poignant messages. Then Dr. Dorcas, amazing breaking down the side effects, adverse effects, and reassuring us with the statistics that these things are the common ones are short-lived, and then we've got the rare side effects. I mean, if you're talking about 1 in 50,000, come on. You know, we've also understood that when we hear things in the news around vaccines and side effects with the vaccines, we have to distinguish between a causality and a correlation. They are very, very, very different things statistically. In research, when you say something is correlated, doesn't mean it's a cause. And causes tend to be more serious and will be taken seriously by this government and scientific community. And then we had our survey, which is still showing that our community, whereas all the other communities that we surveyed were happy to actually take the vaccines when offered for those who hadn't been given a vaccination date. There were still a very, very small number of people from the Black African community, mostly women, who are very reluctant. And in the 10 women who were not really willing to take it, 5 were undecided, 5 said they wouldn't take it. And out of that 5 who said they wouldn't take it, 3 actually said that they didn't think any additional education might sway them. Like I said, this is a webinar that is just to give the information. For people to take the information, we have to remember that COVID-19 disproportionately impacts people from the Black and minority ethnic community. We know that the first 10 doctors that died in the first wave were from the Black and minority ethnic community. You know, so there's so many reasons why Dr. Mike talked about why these things could be so. We know there's all the issues around structural racism, inequality. So we need to have a holistic view, a holistic understanding of the issues that affect our community and make your informed decision. So with that in mind, I want to once again say a big thank you to our speakers, very knowledgeable, and you've made this webinar, I think, a success. I also want to say thank you to our participants who have stayed on and listened. And if there are any of you at all who are still undecided about the vaccines and you want to speak to any of us, please do not hesitate to contact us. Thank you very much also to my co-host, as usual, the beautiful, amazing Mrs. Samantha Prosa, my sister from another mom. And thank you so much. And hope you all have a lovely weekend and God bless. Thank you.
Thank you, everybody. Thank you.
Thank you. Well done, you both. Well done.